Dr. Verst, appreciate you talking about the IND, and the FDA has recently put out a proposed expedited investigational new drug program to accelerate clinical research and development. Do you think their plan will work, or do we need to do more?
I do think that it will take the collective ecosystem to be leaning in to ensure the success. But I think it is a terrific beginning in recognizing the problems and the solutioning that will be required in order to achieve that.
All right, now one of the things you mentioned that I've been toying with in my own mind, and you just touched on it tangentially, so maybe I heard what I wanted to hear, was you mentioned risk. And it has bothered me that when you have low risk, sometimes FDA wants everything done, according to their standard process. But if you have low risk, should we be creating a second standard that says, it's not, we don't know if it works for what it says it's going to work for, but the risk is so low, if you want to try it, you can, and create a new standard? Should we do that? Because that would give us the data to whether or not it works.
Yeah.
Your thoughts?
I do believe that is a terrific question, and I think it's really more risk-based in our approaches, and we've got many examples of that within the clinical development arena supported by the FDA. For instance, risk-based quality monitoring. And I think having the ability to be more, if you will, weighted, and of course that is adaptive with regard to our approaches, and being very focused on that risk-based profile will enable us to speed along processes and reviews, but not jeopardizing patient safety nor data integrity along the way.
And that's our concern, or my concern as well, but do they need a nudge from Congress? I'll get an answer from you later, and I'll do a written question on that one. Ms. Winkler, you highlighted how trial capacity is currently unevenly distributed across the country, with many patients living a long way from the trial site. Well, welcome to my district.
Absolutely.
I'm a long way from any place that does that. I mean, people say, well, why don't you just go to Charlottesville? Well, in parts of my district, it's not Charlottesville you'd be looking at. You'd be looking at Cleveland, because you're closer to Cleveland than you are to Charlottesville, even though you're in the state of Virginia. So what can we do to get more sites involved in the clinical trials? And I specifically want to look at community health centers, particularly federally qualified ones. What say you?
One of the ways to enhance access, and so to get into areas where they aren't today, is to make better use of and clarify the rules for what's called a hub and a spoke model, right? So that you have the really important but paperwork heavy responsibilities of the hub, thinking about this is how we run trial sites, and they hold some of that responsibility for the spoke, so that in communities you could have clinical trials available through the clinicians in the community, and they'll operate according to the rules and regulations, and the oversight of the hub, but it helps structure the mechanisms so that you aren't trying to recreate in a local area where you might have just a couple of physicians who could do some things. Let's empower them to do those some things in collaboration with a hub.
And I would be correct that telemedicine will help with that. Yes?
Yes, there are
Absolutely.
definitely some opportunities in remote monitoring and telehealth.
Thanks. Dr. Wang, your thoughts on how we can get more sites like community health centers involved in these early stage clinical trials?
Thank you for the question. What we know from the Australian experience and from other countries is that public investment in our hospitals and health systems is critical to improving the capacity that they have in running clinical trials, and having a centralized network of these institutions that could be centers of excellence could speak to kind of your concerns today.
All right, if you can do it in 30 seconds, Ms. Winkler, how can using real-world evidence or natural history studies and trial designs help new treatments for rare diseases?
It could be very helpful in helping to structure the trials, as well as to, after perhaps a product is available, to do follow-up and make sure that we have the performance that was predicted in the initial piece. So that data, both before submission and approval and after approval, we need to make better use of all of that information.
I appreciate
it's rare
it.
data.
You did great. I now yield